Good afternoon, everybody. Thank you so much for attending our town hall meeting with Dr. Evans. Um, if you haven't met me yet, my name is Marvo Regendan. I am the Executive Director of Alaska Psychological Association. I'm actually the new Executive Director for ACPA. So it's my pleasure to welcome APA's CEO, Dr. Arthur Evans, to speak to us today. And Dr. Taylor, Rudy, would you mind just doing a quick little introduction for me on him? Because I know you're much better at doing that than I am.
Well, let me just tell you all, we have our own virtual visit with Dr. Arthur Evans. He is the CEO of APA, American Psychological Association. He's been with APA for the past 3 years. He was singled out among many applicants to help reshape the vision for APA, and he's done a phenomenal job. I have the privilege of representing Alaska on the Council of Reps, and I can tell you firsthand, he is very visionary, he is engaging, and I hope that as we have this town hall meeting, that you all will feel free to ask him questions, because part of his vision, part of his goal, when he talks about population health, has a clear impact in the path that we here in Alaska would benefit from. So for you, Dr. Evans, if you would go ahead.
Okay, well, thank you so much, Rudy. I really appreciate that. And thank you for inviting me to be here. Let me get my screen going here. I have to do, can I do screen sharing?
Yes, let me do that.
Okay.
Participants, sorry about that.
Not a problem.
Now I need to find you here. Here we go.
Okay, it says I'm still disabled.
You should now be.
There. Okay, got it now. Got it. All right. Okay. All right. Can everyone see that?
Yes, thank you.
Yes. Okay, all right. Thank you. That's right. I have to wait for all the unmutes. Okay. All right. So, again, thank you so much for inviting me. So what I wanted to do, I have about 30 minutes that we're going to try to talk for a bit and then open it up. So I have sort of 3 big things that I want to accomplish. Tell you a little bit about myself, give you some background on me and how I got to APA. Secondly, talk a little bit about our strategic plan, and then I want to spend the bulk of the time talking about population health. And I want to talk about population health because it's a very important framework for where we're trying to move our field and our association. And over the last day or so, a couple of days, I've had an opportunity to talk to a number of people from Alaska, and it's very clear that the folks there see things very similarly to the way we're thinking about them as we think about population health, and you'll see that when we go through. So this is my dad. My dad was a military man, and I know from talking to people over the last couple of days that there are a lot of people who have come from military families in Alaska. My dad was in the Air Force, and he met my mom, and like many military families, we spent time outside of the country. This is my mom in Japan. These are 2 of her students while we were there in Japan. They got together and they made me, and this is usually where everybody goes, I took some characteristics from my mom, like her as a teacher, her caring nature and wanting to take care of people. Then I took some things from my dad. He was very logical. He was an electronics technician in the Air Force and worked on, this really sophisticated electronics equipment. So he's more sort of the logical side. But I also got some other things from him, like his debonair stuff. The lady there is my wife. She wasn't my wife at the time. She actually made those 2 coats. And that we're wearing there, but I noticed later that she has her hand under my coat, just like my mom had her hand under my dad's coat. I don't know what that's about. I guess it's just that Evans man thing that's going on there. I have three daughters, and these are my three daughters and my wife. So you can see I have an all female household. Even the goldfish was a girl, is all females. But I did get blessed with two grandsons, so we have a little bit of testosterone in the family besides myself. I grew up in Melbourne, Florida. If you look at the map up there at the top where you see that little red star on the east coast of Florida, right in the central part of Florida. And it's right in the shadow of the Kennedy Space Center. In fact, the area that I grew up in is called the Space Coast. And Disney World, which was about 50 miles to the west. So I grew up in a place where the sky was the limit and everybody was happy. A little bit about my educational background. I actually started my education as a music major, community college. I'm a big proponent of community colleges because it was a great start for me. And when I went to community college, actually on a music scholarship, I thought that was going to be my career. But because of some habits that I have developed over my lifetime, like wanting to eat and live in a house, I thought that maybe I should get out of music and get into another career where I thought I could have a more a better livelihood. While I was at FAU or at Brevard Community College, I happened to talk to a teacher who encouraged me to pursue my dreams of going into psychology. I wasn't really sure that that's what I wanted to do. And she took about 15 minutes. It was the very last day that the college was open before the summer break. It was my end of my second year. I didn't know what I wanted to do. I actually was going to come back to college, to community college for a third year and try to figure out what I wanted to do with my life. And she took 15 minutes, talked with me, and it literally changed my life because in that conversation, I told her that I was interested in going to psychology, but I thought that it would take too long and that I was really concerned about, just how long it would take. And she encouraged me to do that and suggested two schools for me to look at, one of them being Florida State, which was up in the north of Florida, and Florida Atlantic University, which was in the south of Florida. And at the time growing up in Florida, thought that Florida State was too far up north, got too cold up there. So I chose FAU. I actually didn't even look at Florida State. I just thought it was way too far north for me. For those of you in Alaska, everything is relative. At the time, that made a lot of sense to me. So I go down to FAU wanting to be the next Bob Newhart for the African American community. And I get down there and it's an all experimental program, but I loved it. In fact, there was not even a clinical psychologist on the staff. I liked it so much that I co-opted and I worked with applied psychologists who were working in the military on Army aviation and really enjoyed that work. Ended up getting a master's at FAU in computer assisted instruction. And then a master's in experimental psychology. My thesis was in computer assisted instruction. So I really loved that part of the field and almost decided to become a cognitive psychologist. But when it was time to choose my doctoral program, I decided that I was going to go back to what really interested me in psychology, which was clinical psychology. And I was fortunate to be able to go to University of Maryland, which at the time was a clinical and community psychology program. And I know that University of Alaska has a clinical and community psychology. So I'm a big proponent of that training, which helps people to understand both systems and people in context, as well as the traditional clinical training. And then I finished my training at Yale, where I did my internship, which is a very psychodynamically oriented program. I should say that while I was at University of Maryland, I had the opportunity to work as an intern at the APA, and I worked with people who were working in public policy. So by the time I had finished my training, I had worked with experimental psychologists, applied psychologists, community psychologists, clinical psychologists, people who were psychodynamically oriented, people who were more psychobiologically oriented, and policy people. And that really shaped my career. I'm so glad to have been exposed to so many different types of psychologists in my field, in our field. And it's really something that shaped my career, which I describe as being at the intersection of practice, policy, and science. Spending the last 20 years of my career before coming to APA in public policy positions in Connecticut and then in the city of Philadelphia. And one of the reasons that I'm so excited about being at APA is that throughout my career, I've pulled on every part of our field, from organizational psychology. I pulled on my training in experimental psychology and my training as a clinical and a community psychologist. You'll see all of those influences in the rest of my presentation, particularly when I talk about population health. But it's a reason that I am so excited about being at APA, because I know what our discipline and profession, the impact that our discipline and profession can have on so many areas that are important to people. And it's really exciting being at APA at this particular time, because we really have an opportunity to position our field in such a way that the public has a much better understanding of what we do and the contributions that we can make. The last 2 years in the association, we've really been focused on a new strategic plan and a set of priorities for the organization. When I was hired, what I was told and what was asked of me was that we really needed to change the organization. That when I came on into APA, we were celebrating our 125 years, and essentially what was told to me was that what got us here over the last 125 years is not what's going to take us over the next 125, and that we were at this really critical time where we really needed to do some self-reflection and figure out, where did we want to go as a field? And we spent the better part of a year talking to our members, talking to our leaders, talking to people outside of the American Psychological Association, and really trying to get a sense of, where do psychologists want our field to go, and where do people want APA, and what role do people want APA to play in that? Out of that came the four big strategic priorities that you see on the screen. I hope you get a chance to look at the whole strategic plan. It's only about 3 or 4 pages, but these are the big ideas that came out of that. When we talk to people over and over again, whether they were early career, late career, researchers, clinicians, didn't matter. People said, we want to see psychology utilized to make a positive impact on the critical societal issues of the day. People said that over and over again. So that turned out to be one of our strategic priorities. People said that they wanted to see us elevate the public's understanding of, regard for, and use of psychology. That people understood that psychology really isn't understood, particularly the breadth of the field and how we're trained, and how our training is different than, say, social work or other parts of the mental health field. People said that they wanted to see our discipline and profession be prepared for the future, that they recognize that many of us are in areas of the field that are being disrupted. Clearly, healthcare is being disrupted. Education is being disrupted. How do we make sure that psychology remains viable? And then they wanted to see APA strengthen its standing as a real important voice for our field. We published the publication manual. We established ethical standards for the field. We do all these very important things for the field, and people thought that it was important for us to continue that. So I wanted to give you that backdrop, because that's so important. What we're doing is something that few organizations do, and APA has never done, which is to say, We're really going to use these strategic priorities to drive everything that we do as an organization. Those, I don't know if we have any organizational psychologists on the call, but you will know that to do this is going to be extremely complex. It's a very hard lift. It's a multi-year lift to reorient the organization to do these things. But it's really exciting to see us make this pivot to these big priorities, and we're already seeing some results in that. So the rest of my time, I want to talk high level about one of the ways that we want to achieve some of those priorities. How do we have an impact on the critical societal issues of the day? How do we help the public to understand our field better? So one of the decisions that we've made recently is that we believe that if we're going to have the kind of broad impact in our society, in our nation, that we need to adopt and embrace a population way of approaching that. And it's going to be clear as I go why we think that's important, but a population health approach is distinct from our traditional way of approaching mental health. And I'm going to share with you how it's different. The reason is because we have some very significant challenges in the behavioral health field. We know that behavioral health issues are ubiquitous, that they're everywhere. They show up in, I was talking to the assistant police chief for Anchorage earlier this morning. We were just talking about how behavioral health issues manifest themselves in all kinds of ways in communities, and they're complex, and they show up in homelessness and child protection in the school system. They show up in our work settings. They show up in every part of our society, and they're complex. But our way of approaching these, our public policy, does not really reflect what we understand about behavioral health issues, and it certainly doesn't reflect our best understanding and integrating that into how we approach that. And so this whole idea is based on the idea that we can do better. And I know that this particular quote from Martin Luther King will resonate with many of you. He says, of all the forms of discrimination and inequalities, injustice in healthcare is the most shocking and inhumane. Now that's really striking, coming from someone who had dogs put on him and was beaten and all of those things. He believed that when we don't have an equitable healthcare system and approach, that it is one of the most discriminatory and unjust things that we can do as a society. So from my standpoint, particularly as someone who's worked in public policy for many years, I think this is really important for us to get this right in terms of our approach around behavioral health. So let me start with this idea that if I'm going to ask you to take and consider a different way and ask our field to take a different way of thinking about mental health, I should at least start with, well, how do we think about mental health today? Now, if I were there in Alaska, this would be the audience participation part, where I would ask you, does this mental model, is this a mental model that most of us have, and what are some of the problems with this mental model? So let me just explain how most of us are trained. We're trained in what I call the black box approach to mental health. We create a black box called treatment. We want people to come to us. We diagnose them, figure out what's wrong with them. We treat them, and then we discharge them and with the assumption that they are well. And that's how we derive our outcomes. That's the primary way that most mental health individuals are trained, whether you're a psychiatrist or a psychologist or a social worker, most of us have this mental model. People come to us, we figure out what's wrong, we treat what's wrong, and then we discharge them and they're well. Now, I said that this would be the audience participation. I would ask you, Well, this has helped a lot of people. Clearly, our outcomes for treating mental health and substance use are as good as many other areas where we are treating chronic health conditions. That's what the research says. But we also know that there are a lot of problems with our approach. And there are a lot of problems with this as a mental model for treating mental health issues. And if I ask that question, you would say things like, well, one of the problems with this as a mental model is that mental health and substance use issues are more like chronic conditions. This is an acute care model. It assumes that if you come, you get treated, and that you leave, that you're well. This is much more like diabetes, where you might have an acute phase, but there is ongoing need for treatment. You would say that one of the major problems with this as a mental model is that most people don't want to come to us. It's a black box. It's scary. We don't know what they do over there. We know that half the people have, or more than half the people who have a mental health diagnosis will not seek out treatment, never come to treatment, and 90% of the people who have a substance use condition will not come to treatment. So most of the people who have behavioral health conditions in Alaska and every other part of the country, and actually every other part of the world for that matter, don't even come to us. We know that when people come, that often they don't engage, that the modal number of outpatient sessions, for example, is 1. So people come and they leave very quickly. We know that in many places, if you have a 30-day program or a partial program or whatever the program is, that it is a box. I intentionally use this idea, this metaphor of a box, because what we ask people to do is to fit into what we've created. And if they don't fit into what we've created, we have names for folks. We call them treatment resistant, particularly in our substance use programs. We say people are not ready. They're recalcitrant. We have all kinds of names for describing people who don't fit, when we really should be looking at, well, how could we better meet this person's need? When I was practicing, I really started to watch my language, because when that language sort of reflected our thinking, and that's not the kind of thinking that we want to have in terms of when people come to us for help. There are lots of problems with this as a mental model, and it doesn't, again, line up with our scientific understanding of mental health, substance use conditions, and there are a lot of systemic problems. But I will tell you that I think that the most difficult thing about this as a mental model is that it constrains our thinking. We're focused on treatment as the only way that we can help people. And so when you hear talking heads on television and they say, Dr. Smith, what do we need? We just had another shooting by a person that we think is mentally ill, or whatever the issue of the day is. And almost all of the time people will say something like, well, we need to have more treatment. Now, I spent my whole career on treatment. I believe in that. I will always believe in that. And I believe that we need more treatment. But I will maintain with you that treatment isn't the only solution. And I'm going to talk about what some of the other solutions might be for us having a more effective approach to behavioral health conditions. So this is a schema that essentially shows how we think about mental health in this country and treat it. The top 25% of this pyramid are people who have a diagnosis. So about 26% of the population has a mental health diagnosis. About 5% serious mental illness. We spend 80% of our resources on that top 5%, and about 20% on the bottom 5%. And so it's the 80-20 rule. It's the exact reverse. And for people below the diagnostic threshold, we spend very little, almost nothing in most places. My budget in Philadelphia was about $1.5 billion. Probably, when I got there, only about 1% of that was being used for prevention, early intervention, everything. Everything was above the line. As psychologists, as mental health practitioners, you know that That doesn't mean that the 75% don't have issues. They're just subclinical. And what we know from research is that many of the people in the 75% will be in the 25%, at some point. But because we don't pay attention to them until they reach that threshold, we essentially ignore them until they're above the threshold. And often we only see them when they're in crisis. Here's the other thing that we should recognize, that healthcare actually turns out to account for and impact our health status very little. Only about 10% of the variance in our health status is accounted for by health care. 90% are things outside of healthcare. It's lifestyle primarily in our behaviors, but our environment, human biology, but we spend a lot of money on that 10%. In fact, next year or this year, we'll spend about $3.3 trillion, that is trillion with a T, dollars on healthcare in this country, even though it accounts for only 10% of the variance in our health status, ignoring often many of the things that have a much greater impact on our health. If you know anything about the American health system, you also know that even though we spend more money than anyone, no one's even close to us in terms of the amount of money that we spend on healthcare, but we lag behind almost every other industrial country in the world. So part of that, I believe, is because of, we're not paying enough attention to some of those other factors. Those other factors collectively are often called social determinants of health. These are just some of those. Many of you know or familiar with those things outside of treatment that impact on that. So what would it look like if we changed our paradigm? So I've been talking about a population approach, and essentially what that means is that rather than only focusing on people above the line, we're really looking at the entire population, and that the goal is not to just treat symptomatology, but it's really to improve the health status of everyone in the population. And that's a different way of thinking. Treating illness is not the same as promoting health. And in a population, a real population health approach, that's what we're trying to do. So this is what this would look like conceptually. So if you take that paradigm, that pyramid, and you divided it between people who are diagnosed, that's that 25% that I showed you. There's another group of people in our communities. These are obviously very rough concepts, right? There are another group of people in our community that are at greater risk for developing behavioral health conditions. People who have experienced trauma, people who are under a lot of stress. We know that the frontline healthcare workers right now are under a tremendous amount of stress and are at greater risk. So we know who the people are in our communities who are at greater risk. And then we have people who are relatively healthy. They're doing fine. Our strategies would look like this. For people who are in that 25%, what we want to do is we want to make sure that we have the most effective and efficient care possible, and that we're using the best science and all of that. And it's important to point that out because when you talk about expanding our viewpoint and thinking about the whole population, often people will say we're abandoning people who have the most serious and significant issues. That's not the case. It is saying that in addition to those folks, we need to be thinking about people who, for example, are at greater risk. And our goal there would be, can we reduce the risk factors? Or if we can't do that, let's intervene at the earliest possible moment. So let's move away from this crisis orientation so that we're intervening early. And then for people who are relatively healthy, how do we help keep people healthy? We do that in other parts of healthcare. Right now I should be exercising more and making sure I'm eating right and those kinds of things, because as a society, we've said that we don't want people to get ill. We don't want people to get cancer. We don't want people to get cardiovascular disease. And so here's some things that you can do to reduce the risk of having those problems. We don't do that in mental health and behavioral health. And so this population approach is, how do we start to think about what we do in this broader sense, so that as psychologists, as mental health practitioners, part of our role clearly is to help people have a diagnosis, but it's also to help the broader population understand what are some of the things that you can do to mitigate and reduce the likelihood that you're going to have a mental health problem, but more importantly, what are the things that you can do to stay psychologically healthy? And if you're at risk again, what are some things that you can do to reduce risk factors? So here's what this might look like. And since I'm talking to psychologists, I know I'm talking to other folks as well, but particularly for psychologists, we always have to have a good conceptual framework. So here's my conceptual framework for what it would take for us to move from a pathology, symptom-focused way of thinking about behavioral health to more of a broad-based population strategy that looked at promoting health. So these are 7 conceptual shifts that I think we have to make in order to do that. I'm going to go through these, and then the rest of the presentation, I'm just going to give you examples of what this will look like, because often what people will say, well, I hear this, I understand this, but can we really do this? And the answer is absolutely, and I'm going to show you examples of my work from Philadelphia where we did. So the first conceptual shift we have to make is to start to think about how we intervene upstream. How do we intervene at an earlier point and not wait until people cross some threshold that allows us to get paid through insurance? Because that's frankly what's driving how we behave as clinicians. It's not our theoretical orientation, it is what we get paid for. And right now what we get paid for is dealing with people after they have a diagnosis. So the first conceptual shift we have to start thinking about is, how do we get upstream? What does that look like? The second is, how do we have a broader set of strategies? I would, if we were having our interactive portion here, I would say, what are the ways that we deal with mental health in our communities? Now, I've done some version of this talk around the country, actually around the world, and in most places, it's 3 things. It's psychotherapy, it's psychopharmacology, and case management. Essentially, that's 99% of how the resources in the mental health system are spent. So one of those 3 areas. I will suggest to you that there are other ways that we can intervene beyond those that can have a positive impact on people's mental health, behavioral health, and can help improve people's behavioral health status. The third one is that it's important to work with that at-risk group, that middle group, and that healthy population group, in addition to the people who have the highest risk. So if you were in charge tomorrow of the Anchorage or the Alaska system, and you were thinking about you wanted to implement this whole population approach, what kinds of things would you do for people who are healthy? What kinds of things would you do for people who are at risk? The fourth is we have to start thinking about health promotion in addition to treating illness. Health promotion is about what are some things that we can do that will actually inoculate us or make it less likely, or maybe lower the impact of mental health issues, in the same way that eating right, exercising help in our physical health. There are things that we can do to help promote good psychological health, and we want to add that to our armamentarium. We want to work in settings outside of treatment. One of the reasons I talk about black box is that almost all of our solutions to the mental health issues within our community are identified as being within the black box. We got to get people into the box. That's how we help them. I want to suggest to you that the issues around mental health are out in the world. They're in the criminal justice system. They're in the schools. They're in our work settings. And that if we really want to have impact, we have to figure out how we have interventions in those places where people are naturally. And then health activation is about how do we help people to take ownership over their own health status, and that might mean you know, the equivalent of exercising or reducing stress in our lives, but really taking ownership. And then the last thing is, how do we work more at the community level of analysis and not only the individual level of analysis? If I were to say to you, what are some things that we can do at the community level that will improve the mental health status of a community? That's different than how we're trained, which is to think about each individual and how we work with an individual. Now, I took a little time to walk through that because I wanted you to understand conceptually. Everything else I'm going to tell you in the next 5 minutes or so here is just examples of how we can do that. And I'm going to run through this because I'm running low on time here. So let me give you a few examples. So in terms of working with people who have a diagnosis, one of the most important things that we can do is make sure that we're using evidence-based treatment approaches. In my work in Philadelphia, very diverse, culturally diverse population. We implemented those practices and made a huge difference. And let me give you an example of that. This is really combining a couple of things. This is a map of Philadelphia. The dots that you see there on the map are programs that are trained up in evidence-based trauma treatments for children. So what we did was, with a federal grant, was to screen children in primary care settings. Kids are going to their pediatrician all the time. Many of those kids have been exposed to trauma, often goes unidentified. We started screening children, about a third of the children screened positively, and then we connected them to those evidence-based treatments so that we were intervening much earlier in those children's lives. Those of you who work in the field, you know that many of the people that we're treating, particularly in our substance use programs, but in our mental health programs as well, have had early childhood traumas that were never treated. You know that. And people live a life of substance use and other kinds of challenges because we didn't intervene. This is an example of using evidence-based practices and working further upstream and intervening much earlier. Similarly, we use psychological first aid in the aftermath of traumas in the community. If there's a community shooting, we would send teams of people trained in psychological first aid, not to treat people, but to help people understand what a normal trauma reaction is, and to help identify resources if people in the community who might be responding and reacting to a traumatic event, if those individuals start to have problems, they know how to access services. This is a program, this is a good example of health activation. Storytelling, African American men, Latino men, Asian men, telling their stories of their own psychological wellness. Now, we intentionally use that language because what we were trying to do is to draw men in to have these conversations. And we would have these storytelling events where men would get up, tell their stories, and then at the end of the event, we would have what we would call a talk back and talk to the audience about, what did you hear? What kind of stories? What did you hear about what these men were doing? We didn't talk about illness. We didn't talk about psychopathology. First time we did, first of all, I thought when we partnered with the organization to do this, that it's going to be hard to get men to do this. It turns out we were not only able to get men to do it, but the first time we did it, we sold out the venue, 300 people. The next time we did it, 600 people. The next time we did it was 1,000 people. This is like 1,000 people at a storytelling event of men talking about their mental wellness. We need to go out into the communities. This is a diverse group of people that we would send out into the community. They would screen people for mental health conditions. People said people will never walk up to a table in Philadelphia and talk to someone about mental health. Turns out people do. And they come up to the table and they will say things like, I have a brother, I have a sister, or I'm experiencing problems. Every time we did this, there was at least one person who was suicidal. One person that we reached, that at least one person, sometimes it'll be multiple people. And so what it said to us is that we have to get out of the black box and we have to get into the places where people are. This is a Southeast Asian community, Burmese and Bhutanese community. Really critical for us to think about how we tailor solutions to meet community needs. So rather than going into communities and saying, here's the solution, come to our treatment program, you go into communities and you ask them. I have this saying, inherent in every community is the wisdom to solve its own problems. And if you ask people, they will tell you. If you want to work effectively with our community, here's what you have to do. What they told us, create a storefront program where we embed mental health practitioners, and people will come to us for English as second language help, immigration help, and when they do, because we have those people embedded within our facility, our program, we can identify people. Very effective way for that community and getting people connected. All right, so I'm gonna stop there and just give you a few examples of how I gave you some examples from my experience in Philadelphia, and not because those necessarily translate directly to Alaska, although I think many of them do, but because I think that the point is that the principles, going out to meet people where they are, listening to communities and letting them define the problems and challenges and the solutions, giving people the opportunity to tell their stories, that those principles translate across a lot of different settings. And what we're trying to do at APA is to take that way of thinking and apply that to our advocacy and to the work that we're doing in the organization. So here's just a few examples of that. Healthcare workers who are on the front lines in the COVID crisis, we created a toolkit for them that helps them to address the stresses that they're dealing with in real time on their shifts, because many of them don't have time to have a group therapy session, but this is something that a tool that we can put in people's hands. Having conversations with the gentleman up top is a pro football player. Actually, later this week, next week, where he's going to be talking about his own mental health issues. Again, sort of taking this idea of normalizing mental health issues and talking to audiences that might not ordinarily hear that. Doing work in our rural communities and our frontier communities, really helping clinicians to understand the unique issues for those communities and the unique issues, particularly for farming communities, and training clinicians to better meet those needs. Those are just a few examples. So with that, I'm going to stop and just say that this way of thinking is where we're trying to take our organization, and I'd be happy to hear and want to hear about what your thinking is. I know that much of what I've talked about are ideas and principles that are really consistent with the way many of you are both trained and the way many of you work. So with that, I'm going to stop right there.
Dr. Evans, thank you very, very much for this presentation. And I do want to open it up if anyone has any questions for Dr. Evans. Well, all of you are struggling with your questions that you may want to have.
Let me throw out a question. I think I know that the UAA people are trained in clinical and community. Could you see the community psychology influence in the way we're thinking? The way we're thinking about population health and how it can play out in communities and the kinds of things we should be advocating for. In terms of public policy.
Yeah.
So I had just a couple questions in terms of your experience. How has this played out in more rural areas, you know, you do the storytelling in Philadelphia, you got a pretty big crowd there to get a critical mass going. How has this played out in more rural areas? And then the other question I have is, of course, reimbursement. How do you get paid? Because some of those things, I like the model. I like being able to address the whole thing, and just logically, it seems like over time it would begin to lower rates of pathology presentations anyway. But how do you get, since we have the fee for service thing going on, how do we get around that?
Good, two great questions. So let me take the first. So what I was sharing with you, I think, as a good psychologist, we always start with a good theory, a good construct, and then we use that then to drive what we do. And in our case, what we're doing is we're saying, look, conceptually, this is where we have to go. Because I've literally done some version of this presentation around the world, and in every place that I've taught, whether it was New Zealand or Sweden or South Africa, people go, yes, of course, that's what we ought to do. Then, if that's what we ought to do, then the question is, okay, how do we do that? And that's where public policy comes in. So right now, I will tell you that there are a number of groups in Washington. Well, I guess most of us are based in Washington. We're a lot of Zoom calling right now, so we're not physically in Washington, many of us. But there are a number of groups that right now are coming together and coming up with recommendations for Congress and the administration around how do we deal with what we know is the coming tsunami of mental health and behavioral health problems because of the pandemic. We know that just based on our experience and research, that's coming. So what I've been doing in those settings, and there are people who share my perspective, is saying, look, we can advocate for more. We can advocate for what we've always done, which is the black box model, which is let's try to figure out how to use this opportunity to get more funding for what we've always done. Or we can do that plus say, this is an opportunity for us to get upstream to fund those kinds of things. And so we're building into the recommendations that we're making, the importance of Congress funding early intervention and prevention programs. And we're also making recommendations that systems administrators, where it's your state agency or local agencies that are responsible for behavioral health systems, that they begin developing interventions further upstream that are much more prevention oriented, that are much more early intervention oriented. So I guess that was the answer to your second question is, well, how are we going to do these things? Now, I did them. I was a commissioner for behavioral health in Philadelphia. I made the decision that we were going to take dollars, particularly dollars, our surplus dollars, and we were going to invest them in the kind of things, I gave you some examples of how we did that. And I can tell you that a lot of those kinds of investments led to literally saving millions of dollars in savings in other ways. I didn't talk about some of the work that we had done around homelessness or some of the other work that we've done, but that work literally saved us millions of dollars over a few years. So it really takes people who are in policy positions, one, understanding this, but then going the next step of actually implementing policy that way. So it can be done. I did it. Other people are trying to do that around the country, actually around the world at this point. But we have to have a very strong advocacy so that you or whoever's running your system has dollars that are not just tied up in treatment. In terms of the rural piece, I didn't talk much about it, but one of the relationships that we've developed is with Farm Aid, and we're working very specifically with them around access to behavioral health services in rural and frontier communities. And this has been really interesting because as we've talked to these folks, so some of you probably know Farm Aid, they work with primarily farmers, ranchers, people doing that kind of work, and they're usually the smaller smaller family farm types of folks. There's this whole, and I didn't know this before I started doing this work with them, there's this whole infrastructure in farmland to help farmers. And one of them is that there are these hotlines or helplines that when farmers are starting to have economic problems, they can call these helplines that will help them, get loans and that kind of stuff. Well, it turns out that that what the people on those lines are saying is that many of the people who call in, they are really, really stressed. Many people don't know that right now farmers are experiencing a crisis, not like anything they've seen since the crisis. I think it was the 70s when we had a farm crisis before. I mean, some of you have been around. I think it was in the 70s when we had the farm crisis. Well, farmers are experiencing the same thing today. The difference is most people don't know that. The suicide rate, for example, for farmers is probably about 2 times that of the general population. It's very significantly higher than the general population. In Wisconsin, where we were last year, I think it was somewhere between 3 and 5 dairy farmers are going out of work, going out of business every week in that state. Tremendous stress. But what these helpline people were saying was, half of the time, a significant amount of the time, what they're dealing with are the mental health issues, people who are suicidal, people who want to hurt themselves, people who have had a farm in their family for over 100 years, and they have the stress. They might be the ones who lose the family farm and the stress that that's causing them. And so, so some of the things that we're doing is helping to train those individuals. But one of the people who is doing that work with us was talking about work that they were doing in some of the local communities where, at the churches and other settings where people are coming and they're talking about their stories and they're normalizing and talking about their experiences, which, people are saying, that's kind of unusual for those communities, but things have gotten to the point where people are now open to those kinds of interventions. So I do think that a lot of those ideas, of course, are going to look different, but the idea that people can normalize these things, I think, translates across different populations.
Dr. Evans, I didn't really have a question, but more maybe a comment and a clarification related to what you're saying. It seems like what you're talking about, a lot of would be embedding providers within systems. My pre-doctoral internship was in a primary care clinic. Sounds like that, in shelters that serve people who experience homelessness, public schools, kind of piggyback on to Dr. Lane's point, that could be how that we deal with the billing issue, is that either grant or directed behavioral, state or county behavioral health funds go to those systems rather than that black box or private practitioner model where you come to my office kind of thing, that we're out in the community in different systems, even police departments.
That's exactly right. I wish I had more time to show some of the examples. We had behavioral health people in all kinds of places in Philadelphia, in libraries. Why do we have people in libraries? Because in urban libraries, that's one of the places that people who are homeless go. And often, sometimes there are challenges with that. We had people in police departments. When people are arrested, there's something called a sequential intercept model, which basically has this notion that in law, if we really want to help get people out of the criminal justice system who have behavioral health issues, we have to think about all of the places that people can come into contact with law enforcement and then embed in each one of those areas a behavioral health intervention or strategy. So at the lockup, for example, in Philadelphia, we had a person at one of the lockups, we had a person there who would screen people, identify people who really needed to be in the behavioral health system and get them connected. We had lots of services in the schools. We had literally people in all kinds of places because the principle that we were following is that if we really want to have impact, we can't expect that people are going to come to us. In fact, we know that's not going to happen. And so then the question is, how do we partner with other people in the community and embed people where people actually go? That was the solution that the Burmese and Bhutanese community came up with, right? They were like, no, because the typical response when, because this is a high traumatized community coming from war-torn places. And so the typical behavioral health response is, okay, we'll build a culturally competent program in your community and put it in your community. Maybe that's the, approach. But when you ask them, they're like, no, that's not what we need. Let's put the person in the place where people are naturally coming. And what happened was, two things happened. One was that the person would intervene in that setting. So in that storefront that I showed you, they might just work with the person in that setting. Or if it was clear that, the person's issues were greater than what could be dealt with there, they would connect them to a culturally competent program outside of that. So they had multiple ways. The point is that if we didn't have the person where the people were naturally going, we never would have had any chance of intervening with them. So your point is right on the money, I think.
This is Hannah Ekstrom. I have a quick question. And first, just a comment. I think for those of us trying to do this work, one of the biggest challenges is taking something so complex and making it simple so we can describe it. And so I really appreciate even those graphics and visualizing and really helping us understand what is it that we're doing, because I think when we think in those complex models, sometimes that becomes a barrier to explaining other people and getting them on board. Could you comment or share any strategies that you have found that's helpful to help share this vision with others and bring them alongside who we need to partner with? And just what have you found really works to do that, to help bring everybody on board with the same vision? In particular, maybe coming from a medical model who have a very different perspective.
Yeah, another great question. I think that it kind of depends on who the audience is. When I'm talking to behavioral health people, I always like to start with that black box. And usually what I do is I ask people to critique the black box. And people get it like that. I mean, people instantly get that there are a lot of problems with our way of asking people to come to us, assuming that when people leave that they're better, forcing people to kind of fit within our way of conceptualizing what their problems are and that kind of stuff. People get that pretty quickly. So then it's pretty easy then to say, what are some ways that we can address some of these issues? If you've been working in the field for more than 3-4 years, you know that there's a problem with engagement. People know that. I mean, the research is pretty clear on that. People know that there's a problem with people cycling through crisis services. So after the critique, it kind of lowers people's defenses around defending the status quo because they know the status quo isn't working. And then we start to talk about solutions. So what's a way, for example, around trauma? Trauma is actually a really good place to start if you're going to start with a community, because people get trauma pretty intuitively. They understand that if something traumatic happens to people, that there's a good likelihood that people are going to develop a mental health problem. We saw that after 9/11, where everyone got that, people were going to have some mental health challenges. So around the issue of trauma, when we've talked to people both in the field and out of the field, and we said, look, we can wait until people develop PTSD and a substance use disorder and all these other problems, or we can try to intervene much earlier. And here's some ways that we know can work. Psychological first aid, for example. That's a strategy for intervening much earlier rather than waiting for people to develop a diagnosis. People get that very intuitively, and I think people support those kinds of interventions pretty readily. I think when we're talking to people outside, I don't really talk about psychopathology or those kind of things. What I talk about is what are the problems that you're dealing. So when I'm talking to police, I'm talking about what are the big challenges that you have in law enforcement. It's, they're dealing with people who they're not equipped to deal with. And so what I'm talking about is let's come up with a solution that addresses that problem for your officers. I never talk about it from my perspective. It's like, how do we help on that problem with your officers? With people in school district, it is, what they're trying to do is to raise the performance level of kids so that they're performing at their best. And, all of the teachers, all the administrators know that if you have kids who are coming from a traumatized community where there's been a lot of trauma, that impedes on their ability to do that. And so the conversation is, how can we minimize the impact that these traumatic events are having on the kids that you're serving so that they can really perform well? In the child welfare system, it's, well, how do we protect children, right? So we know that parents who have significant substance use conditions and significant mental health challenges often are not in a good position to actually protect their kids, or they're not gonna provide the kind of, so it's always defining the behavioral health problem from the perspective of the person in the other system, and then going to them and saying, can we work together on this issue, and talking about it in a way that helps them to understand how this is going to help them.
Dr. Evans, in the interest of time, we have gone a little bit over, and I do want to thank you for this town hall meeting, and I want to thank everybody who has logged in and joined us today. We do have one more meeting at the top of the hour with the board, and I want to make sure that we do get a short little break into it. So with that, I do want to say thank you again. Thank you everybody that has participated. And we have recorded this. We will make this recording available for those who haven't been able to attend with us today, but I'm sure that everybody here has found this a very enlightening and fascinating talk. And again, we will see you in a couple more, at the top of the hour, Dr. Evans, but everybody else who has joined us, thank you so much. And please enjoy the rest of your afternoon.
Thank you all. Thanks for inviting me. And I hope I shared something that stimulate your thinking.
Thank you.
Okay, you take care.
Thank you.